Okay, welcome back. And we're going to flash the dial-in, the call-in line, so that if you do have any questions about what I've talked about so far or anything about chronic obstructive pulmonary disease, please feel free to pick up the phone and dial in. Hopefully I can answer that particular question. One of the slides that I have up is going to talk about smoking cessation as a part of the treatment for chronic obstructive pulmonary disease. And I don't think people really realize that, what options out there are somewhat limited. Chantix is out there, Zyban is out there. And for those people that aren't aware of how Zyban came about, it's actually Wellbutrin, which is a antidepressant. In its clinical trials, they used it in the psych wards, and they just started noticing that after 6 months, a lot of the patients were stopped smoking. So therefore, they had to rebrand it to a different name so that insurance companies would know what they were covering and not covering. And it also was useful that if you had filled a prescription for a antidepressant and were filling out life insurance, you could get dinged because most of the insurance companies didn't want to cover you if you were on an antidepressant because of the increased risk of suicide. That product is still out there. Chantix is a combination of both Zyban as well as a nicotine analog. So that product actually does help to control two aspects of smoking. One, the ritual, and second of all, the nicotine addiction. We have a caller, and it's Rhonda. She has a question. Rhonda?
Yes, hi, Dr. Reiner. I've tried the Chantix in the past, and I had pretty much no results. Plus, I take other medication, and it might have had some affection on that with the Chantix results. But I have been a chronic smoker for over 30 years, and I really want to stop being a slave to that.
Well, you tried Chantix and it didn't work?
Right. I had bad nightmares behind it.
And what else did you try besides Chantix?
I tried the patches.
Okay.
My next step is when I get the money, I will try the vapor cigarettes. But you said so there was another medication possibly. I'm also on psychotropic, or I guess it'd be for psychiatric drugs. So I was wondering if that might have interfered with the Chantix.
It's very possible. I'm not a psychiatric, physician, so there is some interplay between some of those medications, and they could displace one or another. But you must really like to smoke because you have to have a desire for Chantix to work. I mean, you really have to put them down. And like you said, you're a slave to that particular beast. But nicotine is a very addictive substance, and it's right there with cocaine. They did an interesting study where they gave monkeys all the addictive substances known to man, and the monkeys uniformly died on the cocaine, but the nicotine, they used it just as much, but they got sick before they died. So the average pack-a-day smoker will dose themselves 365,000 doses of nicotine in a year. So the tolerance level is extremely high. Plus, there's a ritual associated with smoking, meaning after you eat, in times of stress, when you're talking on the phone. There is one simple technique that I try and tell patients, which is you have to actually plan to stop smoking. You actually have to get yourself ready. And one of the things you can do, the patches help to reduce the nicotine craving, but you have to play a game with yourself. You have to promise yourself that you can do for 5 minutes that would for a lifetime be impossible, because no one likes to think, I'm never going to smoke the rest of my life. But it's such an instant ritual. Anybody who's ever smoked, and I have, their cigarettes are with them. Their lighters are with them. They never leave home without them. They're always within an arm's reach. So you never tell yourself no. You always have that cigarette in your mouth. So the 5-minute interval just gives you that ability to promise yourself, I'm just not going to smoke for 5 minutes. And if you're a busy person and if you're doing things, your mind becomes preoccupied with other things, and that's eventually how you do it, while the patches keep you from going through the nicotine withdrawal.
What happened with me when I quit smoking in 1988, October 5th, the date exact, I went to the Seventh-day Adventist Church. They had like a 5-day quit smoking program that they've sponsored. And the second day that I quit, the key element was water. And they just implied, you know what, whenever you want to smoke, pick up a glass of water and start drinking a glass of water. To this day, I carry a bottle of water with me everywhere I go. I've actually become addicted to drinking water on an everyday basis. And not to mention the fact that they brought in each day, they brought in different people, such as surgeons and what have you, looked at gums, looked at your teeth decay, looked at your lungs. I mean, all that stuff was enough to scare the heck out of me to quit anyways. But water, every time I wanted a cigarette, I picked up a glass of water and I just drank.
And that's a good psychological technique. You just traded something else for the ritual with smoking, and there's nothing wrong with that. You can, chew a piece of gum. That's why a lot of people gain weight after they stop smoking, because they basically have, they're used to putting something up to their mouth, and they're used to doing this thing. So what do? They do food, and that's why a lot of people gain weight. Not to mention the fact that nicotine causes an increase in your heart rate. Your body works harder when it smokes. So when that goes away, you're not quite as short of breath. You're not quite having the same problems. So you do gain weight just from that particular point of it. But that's why what you find when alcoholics quit drinking, they go to sugar, because alcohol in its purest form is a sugar. So they'll trade the alcohol for sugar. One of the things I did want to promise the viewing audience is the Poor Man Spacer, and this is an 8. This is just a simple 8.5 by 11 pieces of paper. I actually have 2 of them. Vern was so nice to supply those. But we talked about a spacer for your inhalers, and the Poor Man Spacer is just rolling up that piece of paper just like that. Imagine I have an inhaler in my hand. I'll shake it up. I'll spray it, and then I'll wait 1 second. And then I'll inhale. And that's the proper way to use a spacer. So,
purpose? What's the purpose?
The purpose is to mist the albuterol so that you have a chance to take it down into your lungs, as opposed to just catching it on the back of your mucous membranes. So most people that use an inhaler will put it close to their mouth and try and inhale it as fast as they can. You're not capable of doing that. You're not capable of inhaling it. First of all, you have a lung condition. Your lungs don't work like normal lungs. So therefore, your ability to inhale quickly is being reduced. So you need to give yourself a chance to do that, which is using a spacer to put it in an area that you can then inhale it nice and slow. And actually, you should still inhale it slow and as you can, because the slower you inhale it, the better it is to get down into your lungs. The chamber that I recommend everybody getting is called an aero chamber, and that aero chamber basically has a little bitty reed at the back of it, so if you inhale too fast, it sounds like you're playing a clarinet, and that tells you to slow down and inhale slower. And one of the things you mentioned, Vern, about asthma and COPD and using inhalers, people that have asthma who use their inhaler more than 2 times in a week, more than 2 canisters in a year or a month, more than 2 trips to the emergency room, are violating what we call the rule of 2, and that means their asthma is not controlled. The more you use an inhaler when you're an asthmatic, the less it works, and that's how people die from asthma. That is not true with COPD. It does open up the airway, and that does cause you to breathe better with COPD, especially before activity. That's one of the main differences between the 2 diseases, is being able to understand that asthmatic is an inflammatory condition, and in order to treat asthma, you have to treat the inflammation. And allergies are one big cause of that. Now, COPD and asthmatics, if you're an asthmatic and you smoke, you are going to develop COPD. COPD at a lot faster rate than if you were not an asthmatic. Not only that, the nicotines and all the irritants flare up your asthma. So you're really messing with fire when you do both of those. And my advice to you is, if you're an asthmatic, is not under any condition should you be a smoker. I wanted to finish up with just a few quick slides, so if we could go back to the slide presentation. Basically, we talked about anticholinergics like Spiriva. These basically reduce the lung congestion and reduce the mucus. Corticosteroids are one of the things that we use a lot in the acute inflammatory response. If you have an infection, if you have a lot of inflammation, they are a great medication, but they are a horrible medication if used frequently. They destroy muscle, they raise your blood sugars, they are a necessary evil, and we should be very careful with them. And here are a few side effects of that: diabetes, muscle wasting, increased risk of infections, cataracts, and dependencies. This slide is kind of busy, but it really shows some of the inhaled corticosteroids are better than others, and you should talk to your doctor about that. And antibiotics, obviously, we use to treat acute infections. Make sure you get your influenza vaccine if you're a COPD patient. That is very important. You want to reduce the risk of infections. And make sure that if you do have COPD, you do see rehabilitation and help yourself. That is going to be the basic talk for this evening. I appreciate everybody tuning in. I hope you found this informative. And again, thank you for tuning in, Pahrump. Have a good night.